Hello, everybody, and thank you for being with us. Uh, Mark is a bit delayed. He sent me an email. He's trying to log in right now, but I think you will enjoy Mark's talk. Mark is the chief of endocrinology at MD Anderson in Texas, and he's going to talk about the current management of thyroid nodules and the current management of the well-differentiated thyroid cancer. There's a lot of changes in this area. Again, I just received an email from Mark saying that he's just logging on right now, but I still cannot see his cannot see him on the attendees list. So bear with me for just a few more minutes. Again, he just sent me the email just a minute ago. Here we go. Okay. So Mark is with us. 1 second. Let me just unmute him. Hello, Mark.
Hello, how are you?
Hi, how are you doing?
Doing very well.
That's great. Thank you very much for joining us. Great to have you. Let me just...
I apologize for the technical difficulties logging on.
No issues. It's always the case.
That's the theme of the day.
Damn technology.
Yeah, but you want me to share my screen?
Yeah, please do. Please go ahead and start the talk.
Okay, and who do we have on as the audience here?
Oh, we have basically, I think, a community of otolaryngologists in this area. So usually there's quite a few from the Middle East wide, from India, some Africa, and some from, I would say, from Eastern Europe as well.
Great. Okay, so let me, do I have I go ahead and share my screen here, correct?
Yeah.
Okay, so I think I'm sharing my screen. Let me know when you can see it.
Yeah, we can see it.
Okay, and let me, let me see if I can move this. Okay. Okay, so you can hear me okay? You can see the presentation okay?
Absolutely.
Okay, and I have roughly 40 minutes. Is that a good?
Yeah, 40, 45 minutes, and have 10 minutes for questions at the end.
Yeah, perfect. Well, it's certainly an honor to present to you all today. I think it's about 5 p.m. there in Dubai, if I'm not mistaken. And I'm sorry this presentation will not be in Arabic. I speak some Spanish, but I don't think that would help you very much. But unfortunately, I do not speak any Arabic. So, but it's good to meet you all and talk to you all from across the world. And I hope that in the current state of the coronavirus, you and your families are all doing well. So today, I thought I would just give a brief update on, certainly I'm not going to be able to cover everything in regard to thyroid nodules and differentiated thyroid cancer in a 40-minute talk, but I thought I would give an update on some areas where I think there's been some recent progress and some of my own, some areas of my personal research and areas where I think that are important for general otolaryngologists to keep in mind as we continue to move this field forward in 2020. So I am the section chief of head and neck endocrine surgery at MD Anderson Cancer Center. And let me just see if I can move my slides here. For some reason, they are not moving.
If you click on it, no, it's not moving.
There we go. Sorry, it was just some kind of technical glitch. So I'm going to cover the molecular genetic testing of thyroid nodules, as well as some updates on differentiated thyroid cancer. So first, let's start with a brief discussion of thyroid nodules. So So we know that the vast majority of thyroid nodules are benign, and that a small minority of them, about 10%, are cancer. And one of the areas of recent technology that has been arguably, I mean, this is controversial, helpful in differentiating between benign and malignant nodules is the area of molecular diagnostics, genetic molecular testing of thyroid nodules, to be able to try to for those patients who have, a nodule that is benign with a high negative predictive value, those patients can probably be followed. And those patients who have a malignant nodule with a high positive predictive value would go to surgery. And so it can potentially help differentiate between patients who need surgery versus those who do not. So just a word about molecular genetic testing. So there are a number of commercially available tests, and I do not have any sort of interest in any of these commercially available tests, nor any association with any of these companies. But those include, Afirma and ThyroSeq. You probably heard of those tests. These are sort of next generation sequencing and or quantitative PCR to look at multiple biomarkers to assess whether or not we can differentiate between benign and malignant nodules. You can also look, though, at specific genetic mutations. And so I just wanted to make a quick point and differentiate between these commercially available tests, which tend to use a whole platform of genetic mutations and specific mutations. For instance, the BRAF V600E mutation. You can actually take an FNA of a thyroid nodule and specifically just look for the BRAF V600E mutation. So if that nodule has that BRAF V600E mutation or a RET PTC mutation, for instance, those nodules are 100% of those are going to be papillary thyroid cancer. So for RAS, as another example, about 50% of those who have 50% of those thyroid nodules that have a RAS mutation end up being malignant, or PAX PPAR gamma is another example. About 50% of those have malignancy, but those are individual mutational tests that can be done, but they're rarely done for thyroid nodules outside of the setting of a commercially available test, which sort of tests a whole panel of these genetic mutations. And so a couple of principles of genetic molecular testing for thyroid nodules. I think the first principle is common sense. Only do it if it will change your management. So these tests, depending on what the local medical environment is in your particular country, they can be expensive. In some countries, the national health insurance or private insurance may cover it, but otherwise, these tests can run $1,000 or several $1,000s in some cases. So only do it if it's going to potentially change your management. If you have a patient who is going to want surgery, regardless of what the results of that test are, it doesn't obviously make sense to do it. And then choose the molecular test based on treatment goals. So if you're trying to avoid a surgery, if it's let's say it's an elderly patient and you'd rather not operate on the patient would rather not have surgery, then you want to choose a rule out test. So these tests are Afirma is probably the most well-known example of that. It's and with that type of test, you're looking for a high sensitivity and a high negative predictive value, because if you have a test that has for instance, a 95% negative predictive value, and you get a negative result, then you can pretty safely avoid surgery in that patient. Whereas if you're looking to confirm decision for surgery, if you have a young patient who's leaning towards surgery, but is not quite sure, then you could do a rule-in test, which ThyroSeq has been a traditional example of that, which has a higher specificity and higher positive predictive value. And if you get a positive result, then you take the patient to surgery. Traditional examples of a rule-in test would be like the ThyroSeq version 3, University of Pittsburgh, Thigenex, Thyramir, while a traditional rule-out test would be something like Afirma, which is marketed by Veracyte. Now, these tests are constantly changing in terms of their specificity and sensitivity, positive and negative predictive value. So you do have to keep up with the literature. You know, we're now on version 3 of ThyroSeq, as well as Afirma has come out with their new gene expression classifier. So these we have to update the sensitivities and specificities as we go. I did want to mention one other newer test. This is from a company called GenePro Diagnostics, which is based out of Brazil. Just as a disclosure, and I'll talk about this study later, we participated, MD Anderson Cancer Center, were one of the sites that participated in a study evaluating this particular molecular genetic test. So they did support the funding for that clinical trial. I have no other association with the company in terms of any other interest in this company, but they did support a clinical trial that we were a part of at MD Anderson. It's a 10 gene classifier. It has 4 epithelial genes increased in cancer and 6 inflammatory and stromal markers, which allow to better identify benign cases. And it's designed in a multiplex quantitative PCR diagnostic kit format. And so the reason why that's important is that it can be run in widely available quantitative PCR diagnostic platforms in reference laboratory across the world. So, for instance, they're now we're going to talk about some of the data behind this particular study, but this study is now being used quite a bit in Latin American countries, in Brazil and in Chile, where it originated. In several other Latin American countries, because it can be run out of local labs, and you don't have to send in the FNA to a centralized location. For instance, you know, Afirma would be like a centralized lab in the United States that you would have to send it to. So this study is this new thyrogenetic classifier is based on 2 independent prospective multi-center double-blinded studies. The first was in Chile, looking at over 3,000 patients, and then the second was a multi-center study in the United States with 8 different centers enrolling about 855 patients. And these were Bethesda 3 and 4 patients. So these are exactly the type of patients that you would want to potentially know. Just as a reminder, Bethesda 3 and 4 are like the follicular lesions, atypical cells of undetermined significance, and follicular neoplasms. Those are the type of FNA results that are classified as a Bethesda 3 and a Bethesda 4. So if you have those, you may want a molecular genetic test to help differentiate between which patients you want to take to surgery versus those who you do not. So just to look at a few of the data here. So in terms of what's been done, what's in the literature, evidence-based for different molecular tests. So you've got, you know, Afirma, ThyroSeq, Thigenex, Thyramir, this MIR-Thype, and then ThyroidPrint, which is the study that it's actually no longer under review. It's been published now in Thyroid. So this details the number of biomarkers that are included in each of these tests. Whether or not the data was based on a multi-center study, whether or not it was prospective, double-blinded. You can see for the ThyroidPrint, the answer is yes to all 3 of these. The size of the validation set, and so you look at the data here. So I think it's this type of data can be overwhelming. So I think the most important thing is to look at the negative predictive value and the positive predictive value. So you see for all of these tests in the current versions, the negative predictive value is very high. So these tests, whether or not they were traditionally classified as a rule in or rule out, they've all sort of drifted toward a pretty high negative predictive value as they've come out with newer versions. So Afirma, 96% negative predictive value, ThyroSeq, 97%, the ThyroidPrint, 95%. So if you're looking for a test to rule out malignancy, you're trying not to operate on a patient, any of these tests will work. The interesting thing is the difference in the positive predictive value. So if you get a negative result, you know, for any of these tests, you're feeling pretty good about avoiding surgery. But the question is, if you get a positive result, you know, what does that mean? So if you look at the positive predictive value of these currently available tests, you see Afirma is about a 50%. So you can tell somebody if they get a positive Afirma test, it's about 50-50, whether or not that's going to be a malignancy or not. ThyroSeq is about 2/3, 1/3. So 2/3 of those patients, if they get a positive ThyroSeq result, would have a malignancy versus a third who would have benign. The thyroid print is actually, based on these two clinical trials, is actually the highest of any of these tests, being 78%. And the reason why I mention this numbers to this audience is, again, I don't know what, and this is something we can talk about maybe in the discussion later. I don't know which of these tests are available in your various the various countries of those who are in the audience, but this is a much cheaper test, the thyroid print, because it can be made locally available. Now it requires local labs to work with the company to sort of get it started in individual countries. But I just wanted to mention it in case you hear about it in the near future. So some other practical considerations when considering molecular testing. Certainly, you need to look at what is your malignancy risk based on the ultrasound. You know, that's based on the nodule size. Also looking at growth. I mean, if you have a nodule that looks very concerning on the ultrasound, irregular margins, microcalcifications, it's not really going to matter what the molecular test result is. You're gonna that's a suspicious nodule, and so, you know, unless you're going to observe that patient, which is another option for micropapillary carcinomas, you're probably going to end up doing surgery. So, and then you have you know, other factors to consider: patient age, their performance status, what the patient's disposition is for surgery for observation. Again, if the patient's is going to opt for surgery no matter what, then it doesn't make sense to do a rather expensive commercially available test. So, and again, these Afirma and ThyroSeq, these traditional molecular genetic tests, do require sending the specimen to a centralized lab, typically in the United States, and that's why they run several $1,000s. So this new genetic molecular test, we published this data. It was published several months ago. Actually, it was just the print was just published in May, but it was e-published in February in Thyroid. This test is already available in Brazil and Chile. It is coming to Europe and some other Latin American countries soon. I'm not sure about the Middle East. You can certainly talk to Hernan Gonzalez, who is the head and neck surgeon at the Pontificia Universidad Católica de Chile in Santiago, who has developed this technology. It is much cheaper than the currently available U.S. tests. Does not require sending sample to the United States, and ultimately will not require centralized processing. So it will be able to be done, be able to put in particular kits that can then be sort of exported to individual practices and don't even require sending it out to a lab. So I just wanted to mention that is something that is on the horizon. So the next thing I wanted to discuss is getting into sort of thyroid cancer. As we all know, there is a new AJCC 8th edition cancer staging system. I just wanted to briefly mention a couple of the changes in terms of thyroid cancer in this new staging system, and I want to mention them sort of in the context of some controversial areas in the field, and so and particularly related to decisions with regard to surgery. You know, whether you do a thyroid lobectomy or a total thyroidectomy. And so these relate to some of these issues that have come up in the changes in the staging system. So I wanted to briefly mention that. So, for instance, if one of the changes in the new staging system for thyroid cancer is in the T staging, where you now have this T3A and T3B status for thyroid cancers, where it used to be that if there were any even microscopic extrathyroidal extension, So you don't even see any gross extrathroat extension surgically, but you get a pathology report, which is common in thyroid cancer. It's common if you've got an isthmus tumor, or it's common for these tumors just to be located near the margin of the gland, and you get, this microscopic extrathroat extension. Well, what does that mean? Used to be those were classified automatically as T3. Now they are not. So we'll talk about some of the data for that. Now, only if they have extrathroat extension invading the strap muscles are they classified as a T3 tumor, and that's a T3B. And then, of course, if they've got extrathroat extension extending beyond the strap muscles, the subcutaneous soft tissues, larynx, tracheoesophagus, recurrent nerve, those are T4 tumors. So the two ways that you can now be a T3 are if the tumor is over 4 centimeters, or if it's got gross extrathroat extension invading strap muscles. So, and this is some data that we published in Thyroid a couple of years ago. It supports this change. So it supports this change for why microscopic extrathroat extension. So this is the METE. These are if you look at these, and they're a little bit bunched together, but for those tumors that are less than 4 centimeters, whether or not they have microscopic extrathroat extension or not, these lines are essentially the same. So it doesn't make a difference, and so that supports that we don't need microscopic extrathroat extension to be a factor in the T staging of these tumors. And similarly, if you look at those tumors that are over 4 centimeters, whether or not they have microscopic extrathroat extension or not, you see the yellow and the green lines tend to overlap. So the size still makes a difference, and that's why you see this p-value here, because the difference between those that are over and under 4 centimeters. But when you compare the microscopic extrathroat extension to those that do not, based on tumor size, you do not see any difference there. And so that's supportive of that change. Now, in terms of end staging, the only real change is now the level 7 nodes, sort of the superior mediastinal lymph nodes. Oftentimes these are resected in block with the level 6 central compartment lymph nodes. Those are now classified as N1A instead of N1B. So those are included in the same category as the central compartment lymph nodes. Again, these are the superior mediastinal lymph nodes that are a little bit below the clavicle. So that's the only change there. And then there's been no change in the distant metastatic status. When you look at the group staging, you're all very familiar that the age makes a difference in terms of the staging in thyroid cancer. That's one of the unique aspects of thyroid cancer staging as compared to most other cancers. So this age cutoff was changed from 45 to 55. So now, so the new sort of age cutoff is 55 years old in terms of staging. And what that means is for those patients who are less than 55 years old, it used to be less than 45. Now it is less than 55. That you can only be stage 1 or 2. You're either stage 1 if you don't have distant metastasis, or you're stage 2 if you have distant metastasis. So that's the new staging there. Whereas if you're older than 55, you run the whole gamut of staging from 1, 2, 3, and 4. And it's largely based on, stage 1 being those that are T1, T2, stage 2 being those that are stage 1 or 2 and N1, and then stage 3 being T4A and stage 4 being T4B patients. So that's basically how that staging system breaks down. And so when we compare the eighth edition to the 7th edition, this is another paper that we published in Thyroid a couple of years ago. You do see some stage migration when you so if you compare this study essentially compared 2,500 patients who were staged according to the 7th edition versus the 8th edition, and you see more stage 1 patients now and fewer stage 3 and 4 patients, and that's because of the age cutoff change and because of this T3 status change that I mentioned, which now these patients are staged a little bit lower than they were previously. So we talked about the T stage, the changes, the minor extrathroat extension no longer affecting the T category, the T3 now being based on either greater than 4 centimeters in size or gross extension invading only the strap muscles, the N1A now including level 7 lymph nodes, and the group staging, the age being raised from 45 to 55. So one of the things that I think we need to consider in the future, in this, I hope you can follow the thinking here. This was a study that, this was based on this study that one of the studies I mentioned previously published a couple of years ago in thyroid, looking at survival in differentiated thyroid cancer. One of the things that I think is important for us to keep in mind is that stage 2 patients, so if we look at stage 2, so we know that how do you get to a stage 2 being less than 55 years old? Well, that's if you have distant metastatic disease. But we have to remember that these, and this was, we showed this in our data, that these patients who are stage 2 and are less than 55 years old have a poorer disease-specific survival than stage 2 greater than 55. And that's because the reason that these patients are classified as a stage 2 is because they have distant metastasis. And really, when you compare them, they have a similar prognosis in terms of survival to somewhere between stage 3 and 4 patients. So I think this is something that may change in the future. This distant metastatic patients who are less than 55 and have distant disease, maybe we shouldn't classify them as a stage 2. Maybe they should be classified as at least a stage 3, and maybe, you know, even you could argue a stage 4 based on this type of data. The other, and this is more data to support this. I'm not going to go into detail about the statistics here, but supporting that these patients who are who are less than 55 years old in M1 have a significantly worse prognosis than all the other ways that you can be a stage 2, which are for patients greater than 55. The other issue that I think is important that we consider for the future is, should strap muscle invasion continue to mandate a T3B status? So should we, just because the disease is invading the strap muscles, should that automatically get us that high of a T stage? And so that's certainly controversial. This was another study that we published in Annals of Surgical Oncology in 2018. Asking this question: does strap muscle invasion alone influence recurrence and survival in patients with differentiated thyroid cancer? And certainly, we did not see any difference in disease-free survival when you look specifically at strap muscle invasion as compared to perithyroidal soft tissue invasion. And so that is something that we need to continue to keep in mind. So this is for instance, the multivariate analysis, when you compare gross strap muscle invasion to perithyroidal soft tissue invasion versus the reference group of no extrathyroidal extension, these p-values here are not significant. So it is something to keep in mind that strap muscle invasion may or may not impact ultimate survival. So I want to talk a little bit about surgery, since many, if not most of you on the call are surgeons. And so surgery for well-differentiated thyroid carcinoma. So this is an interesting perspective from 1924, so 100 years ago, that it says, we have formed the opinion that radical removal of the thyroid after it is possible to diagnose cancer clinically is a useless procedure. In every case of cancer of the thyroid, the diagnosis having been made clinically, which we have treated, death has been hastened by operation. So just shows you how far we've come with thyroid surgery in just the last 100 years. I would hope that now we're not hastening death by operating on thyroids. So just to briefly mention the changes in the ATA guidelines, there will be some new ATA guidelines which will be coming out probably in a year or so. If we go back to guidelines, so there was the ATA, this is the American Thyroid Association 2009 guidelines. Then there were the 2015 guidelines, and again, the next guidelines will be somewhere in 2021 probably. The guidelines at that time were for patients with a tumor greater than 1 centimeter. The initial surgery should be a total thyroidectomy. That has obviously changed in 2015. Now, for patients with thyroid cancer that is between 1 and 4 centimeters, the guidelines sort of suggest a total or a lobectomy are sort of equally appropriate. And so I think it is important, though, as we as we think about this, this idea of whether to do a lobe or a total for, a 1 to 4 centimeter tumor, or even a tumor that's greater than 4 centimeters in some cases, if you're considering a lobectomy, you do need to look at the ultrasound characteristics. So this is a slide looking at the risk of tracheal invasion of papillary thyroid cancer. And you can sort of look at this. There is evidence to suggest that you can look at this sort of angle of the disease against the trachea that may give you an indication on the ultrasound of how likely that disease is to be invading the trachea. So if it's a more of an acute angle, if it's like this, that it's less likely to be invading the trachea, whereas if it's more of an obtuse angle, sort of this sort of pattern of spreading along the trachea here, then that may be more risk to invade the trachea. And you're probably going to want to plan a total thyroidectomy in those patients. Also, where the tumor is located. So these posterior located tumors that are, the trachea being here closer to the recurrent laryngeal nerve inlet or the tracheoesophageal groove, are going to be a little bit higher risk, especially if there's extrathroatal extension in that area. So we know that for the smallest cancers, there's now this idea that that thyroid lobectomy is probably most appropriate, whereas also observation can be considered as well. So that's why it says, in these 2015 guidelines, if surgery is chosen, meaning that observation or a thyroid lobectomy are equally advocated there. And so I think we've seen, for the least aggressive thyroid cancers, we've seen a definite increase in the incidence. And I'm not going to get into all the sort of the incidence data that we have, but we do see that now we're diagnosing more of these aggressive thyroid cancers, and that's largely due to increased imaging. Although it would be interesting to look now in this COVID era, you probably see a decreased incidence of these thyroid cancers now that patients are not getting all of this extra imaging. But the treatment has tended to go down, less surgery, even less radioactive iodine. We're not going to get into that too much either, but certainly the guidelines have become less favorable toward radioactive iodine, and only really only utilizing it for high risk cases. While the most aggressive thyroid cancers, the incidence and treatment has sort of stayed level. So these changes in the guidelines are because survival and recurrence outcomes are very similar following unilateral or bilateral thyroid surgery. That's the first reason. And this has been looked at in several large studies from Japan and New York, showing 100% disease-specific survival in well-differentiated thyroid cancer treated with a thyroid lobectomy. So it's hard to beat that. Thyroid lobectomy alone is often sufficient for these patients. There's more selective approach of radioactive iodine ablation of these patients. This was a paper that was published back in 2012 now, but this is sort of started the messaging, and this was published in the New England Journal of Medicine, that that lower doses of radioactive iodine were generally more favored, and so this is a table from the newest guidelines looking at risk of structural recurrence. So you've got this idea that after you remove a thyroid cancer, you break it down into low risk, intermediate risk, and high risk, and that's based on a number of different factors, but it's actually a continuum here. So the highest risk factors being gross extrathroatal extension, although I think that is arguable. It depends on where that extrathroatal extension is. If it's anterior, it's going to be much more problematic than posterior extrathroatal extension. I'm sorry, if it's anterior, it's going to be much less problematic than posterior, because the strap muscles can be easily resected, while tumor that's stuck to posteriorly to the recurrent laryngeal nerve and or trachea is more of a problem. And then larger lymph nodes, distant metastasis, obviously puts you in the higher risk category. And these patients are likely getting radioactive iodine, whereas the low risk are typically not getting radioactive iodine, and the intermediate risk are sort of plus or minus. And many of these as I mentioned, many of these low risk and intermediate risk patients no longer are being recommended for radioactive iodine. So that's another reason why we've sort of changed the approach to more thyroid lobectomies, because fewer of these patients are indicated for radioactive iodine. So we also know that about 75% of thyroid lobectomy patients will not require thyroid hormone replacement. So that's a plus for thyroid lobectomy. And then follow-up paradigms for our endocrinologists have moved away from this idea of doing these whole body radioactive iodine scans, at least in most contexts. And so most people no longer doing yearly whole body radioactive iodine scans, and they're rather following these patients with just neck ultrasound. We also have to consider risk. So we talked about that there's not really much difference in survival. There is, if you're doing a thyroid lobectomy, you do have to take into account, and I always will counsel a patient that there's about a 15% risk that in the future you may have to take out the other lobe of the thyroid. And that's not necessarily for, quote, recurrence, although it could be, but it's often just because they could develop another thyroid cancer in that lobe of the thyroid. So, but that's not a huge risk. And certainly if it were me, I would want to take that chance and save my other half of my thyroid if possible. With the total thyroid, there are going to be more recurrent laryngeal nerve injuries and postoperative hypoparathyroidism. That cannot be argued. That's common sense. And also there's data to support it. This was a study that was published about 6 years ago now, looking at risk of complications by surgeon volume and type of thyroid. So these are low, intermediate, and low, intermediate, and high volume thyroid surgeons, whereas high volume thyroid surgeons are those that do over 100 a year. So even, let's just look at this light gray area for the highest volume thyroid surgeons. Those are doing over 100 a year. If you compare a thyroid lobectomy to a total thyroidectomy, you see about double the complication rate. And that's even for patients for physicians, surgeons who do over 100 a year. So no matter what group you look at, the low volume, the intermediate volume, the high volume, you're going to see more complications in a total thyroidectomy cohort versus a thyroid lobectomy. It's common sense. You're putting the parathyroids at risk. You're putting the recurrent laryngeal nerves at risk. So I think that's important for all of us surgeons to recognize and to counsel our patients on that. And even with thyroid hormone replacement, there may be differences in quality of life. So I think this is an area ripe for future study. I think that there will be prospective data coming out on this at some point, sort of looking at following long-term total thyroid versus thyroid lobectomy patients and sort of seeing what are their differences in quality of life. And I think you probably will see a difference in the better quality of life for the thyroid lobectomy patients, all things being considered. And you even see this in sort of very fine measures of vocal function when you're looking at the sort of the grade of the voice and the roughness of the voice. Those patients who have a lobectomy tend to score much better than those who have a total thyroidectomy. I mean, obviously that's related to not only recurrent nerve, but also superior laryngeal nerve issues and others. And you see a better frequency max and a pitch range for lobectomy versus total thyroidectomy patients. So I think that's important to keep in mind. We also have to consider this sort of idea, and this is where I think that when we look at quality of life indices that have been validated, I think we'll see this in studies that there are a lot of patients out there who will say, ever since I had my thyroid removed, I've never felt the same. And they tend to be young women that sort of and a lot of this may overlap with other hormonal issues, but will complain of fatigue, weight gain, brain fog, and they have normal thyroid hormone. And so they're being given Synthroid. They have normal thyroid hormone replacement, but they will complain that they just feel differently in one of these ways. And it's hard to put your finger on it about why, but there may be something to that. And then also this idea of globus sensation. I think that's something that we all see occasionally after thyroid surgery that may be more of a factor after total thyroidectomy. So I want to, in the last few minutes, I want to go over is a total thyroidectomy necessary? And I want to bring up a couple of different sort of scenarios. The first is extrathyroidal extension. So That's the question. Is a total thyroidectomy necessary in the case of extradural extension? As I showed earlier, strap muscle invasion may not change disease-specific survival, and this is this is based on this paper we published several years ago. It's also important to note that, as I mentioned earlier, anterior strap muscle extradural extension can be resected in block with minimal added surgical morbidity. You just resect the sternothyroid muscle. It's not too technically complicated, and there's really no significant morbidity to that. But posterior extension, when the tumor, you can see, is sort of interdigitating between the tracheal rings here, or it's stuck to the nerve and or the esophagus. As you can see here, this is the esophagus, this is the nerve. That could be much more challenging because even if you get a gross total resection, you're going to be concerned about microscopic disease, and radioactive iodine is more likely to be indicated in those patients. So these patients with posterior extension, they're going to need a total thyroidectomy, hands down. I think the jury is out on this anterior strap muscle involvement being necessary to do a total thyroidectomy. I think a thyroid lobectomy is often equivalent in that case, but it certainly is controversial. This was this is actually Brazilian. There are probably no Brazilians on the call, but anterior extension to the straps, everything's usually okay. Posterior extension, there's a problem there. So I would say, is total thyroidectomy necessary when there's gross, significant, and posterior extension? Absolutely yes. When there's minor extension or especially and anterior extension, then I think not necessarily so. I mean, it's not wrong to do a total thyroidectomy, but I don't think you have to. I think that you can resect that strap muscle and just do a lobectomy in many cases. What about lymph node metastases? So we published this paper, Association of Lymph Node Density with Survival of Patients with Papillary Thyroid Cancer. This was in JAMA Otolaryngology Head and Neck Surgery. This was 3 years ago now, looking at 2,500 patients with a median follow-up of 55 months. And the lymph node density just equals the ratio of the number of lymph nodes positive to the total lymph nodes removed. And this number may be more important than the total number of metastatic lymph nodes, because this is just sort of a caveat to keep in mind that that when we're looking at lymph node metastasis and thyroid cancer, we also have to look about not only how many were positive, but the total number of lymph nodes that were removed. Because if a patient had one lymph node removed and that lymph node was, or excuse me, if the patient had, let's say, 5 or 6 lymph nodes removed and all 5 or 6 of those were positive, that's a different situation probably than a patient who had 50 lymph nodes removed and 5 or 6 of those were positive, because that represents a different degree of dissection and a different lymph node density ratio of positive nodes to total nodes removed. And we showed that when you look at overall survival, I'm not going to go into all of these curves, but in disease-specific survival, that it's that this lymph node density actually can predict, in some cases, as well as the AJCCC overall staging system. It's also important to remember that micrometastases do not necessarily require more aggressive treatment. And even macrometastatic risk is mostly in terms of the lateral neck recurrence. What does that mean? So we know from studies such as this study based out of Korea that there's really not any difference in survival. If you do a prophylactic central compartment dissection, for instance, you're not going to find any difference in survival between those patients who had micrometastases in the lymph nodes versus those who did not. So that reflects these two top lines. There's no difference there. You do see a difference in the recurrence if the patient has macrometastasis. That means if they've got large lymph node metastasis, in the central compartment that are clinically apparent, whether that be on the preoperative ultrasound or you see, during the surgery, with the caveat that it's often difficult to tell during surgery because lymph nodes can be enlarged due to just thyroiditis alone. But if you see it in large discolored lymph nodes, it looks like a metastasis. That's a grossly macrometastatic lymph node. So it's important to realize that although that affects disease-free survival, most of that is that it increases the risk of lateral neck recurrence. It's not that it necessarily changes their overall survival. It's just that it changes the risk that in the future that they may have a metastasis in their lateral neck, because it shows that they've got larger lymph nodes. And so I would say that's not the biggest deal, because those lateral neck lymph nodes can be resected down the road. If a patient, we've all had this happen, a patient shows up with has had a history of a thyroid surgery, plus or minus a central compartment dissection, and they show up 5 years later with the lateral neck lymph node. Well, you can just do a lateral neck dissection and take that lymph node out along with the other lymph nodes in the lateral neck, and it doesn't particularly affect their survival. So I think that's important to remember. So in terms of lymph node metastasis, I think when there are macroscopic lymph nodes, and there's many of them, yes, I think that a total thyroidectomy is indicated. But when it's microscopic and there are few of them, I don't think you need to. So, if you're doing a thyroid surgery and you're evaluating the central compartment and you don't really see any lymph nodes that look too abnormal, but you decide, hey, I'm going to send a frozen section of, a few lymph nodes, and the pathologist says, yeah, there's a tiny focus of papillary thyroid carcinoma in a few of these lymph nodes, then I don't think you have to do a total thyroidectomy, nor do I think, if you get that on a pathology report, that necessitates a completion thyroidectomy. So my general philosophy for thyroid lobectomy is, in the absence of significant gross posterior extradural extension or macroscopic central compartment lymph node metastasis, most patients with less than 4 centimeter papillary should undergo thyroid lobectomy. And you can even make this argument for a little greater than 4 centimeters. And that is, unless the endocrinologist or patient have strong preferences otherwise. You should always obviously speak with the endocrinologist and the patient and respect their wishes as well. So I'm gonna, in the interest of time, I think I'm gonna skip over this section of detection of central compartment metastasis. I'm not gonna go into this in detail, but just to say that the high definition ultrasound is the gold standard for detecting lymph node metastasis in thyroid cancer, but it is challenging with an intact thyroid. We don't typically recommend a CT neck for the purposes of a central neck evaluation. And as I mentioned earlier, intraoperative inspection of sub-centimeter lymph nodes, even lymph nodes that are up to a centimeter in size, is unreliable to determine the presence of metastasis, because so many of these patients have confounding thyroiditis that you can't just look at the lymph node and say, this lymph node's enlarged, it's firm, it's going to be metastatic papillary. That's not necessarily the case, because a lot of those are just reactive lymph nodes to thyroiditis. Certainly, there's the ongoing controversy in terms of whether or not to do an elective dissection of the central compartment. There's various approaches to the central compartment. You can do a therapeutic dissection for known disease. You can do an elective dissection even if you do not have proven disease, and that's controversial. And you can do a dissection based on frozen sections. So you can send a frozen section of a lymph node, and if the lymph node's positive, you can complete the central compartment dissection on that side. You typically should get 12 plus or minus lymph nodes, plus or minus 5 lymph nodes as a yield in the central compartment. If you're going to do a central compartment dissection and you're routinely getting 3 or 4 lymph nodes, that's not an adequate central compartment dissection. It's not to say that you need to be even doing an elective central compartment dissection, but that's not really a full central compartment dissection. And these number of lymph nodes vary based on patient factors such as age. Younger patients tend to have more lymph nodes. Also, the pathologist. So how meticulous the pathologist is looking at the specimen, and patients with disease tend to have more lymph nodes. So the American Thyroid Association guidelines continue to recommend for that a prophylactic or elective dissection does not need to be done for small tumors. It can be considered for larger tumors, and this is sort of where the area of controversy exists in terms of the larger tumors. When you look across the board, British Thyroid Association, the European Thyroid Association, LATS, Latin American Thyroid Society, you see that it's all all of these sort of recommend the same. You consider this elective dissection for T3, T4 tumors. it's really not done by high volume thyroid surgeons. Typically don't do it for smaller tumors. The goal of what you're doing with, so for an elective central compartment dissection, the question that you always need to ask yourself as a surgeon is the number of central compartment dissections needed to prevent one recurrence. That should not be disproportionate to the number of central compartment dissections per complication. So for instance, if 1 out of 10 of your central compartment dissections, you've got an issue with significant hypoparathyroidism and or recurrent nerve issue, then that's probably too much to justify it to prevent one, recurrence out of 20 or 30 patients, for example. In terms of the lateral neck, we only do this as a therapeutic intervention for known disease in differentiated thyroid cancer. It's typically a 2A, 3, 4, and 5B dissection. Levels 1, 2B, and 5A rarely are involved with metastatic disease. It's important that 5B be dissected. So these muscles can typically be pulled. These lymph nodes can typically be pulled medially under the sternocleidomastoid muscle. So you can get pretty far back in 5B and removing these along with the level 4 lymph nodes, because when there's disease in level 4, which is common with thyroid cancer, when there's lateral neck disease, there's often disease in level 5B as well. So those lymph nodes can be removed without doing a formal 5 dissection. You don't have to identify the spinal accessory nerve because you're low in the neck. You just pull those 5B lymph nodes medially under the sternocleidomastoid muscle with the specimen. And so this is the location of those 5B lymph nodes that you just pull under the sternocleidomastoid and keep it in continuity with your level 2A, 3, and 4 specimens. Level 5A rarely has metastases, and so you typically don't need to dissect that area. Postoperative radiation, there's really no role for routine adjuvant radiation therapy for patients with differentiated thyroid cancer. And it's a very, very select case where there's local invasion of the trachea and esophagus with a poorly differentiated histology, histopathology. That's the only patient that it's really ever considered. So we've come a long way. This is my last slide. This was in 1956. We've come a long way in the last 100 years, as I showed earlier. But this is a slide from 1956 saying an article saying the optimum treatment for thyroid cancer depends on the pathological type of the tumor present and the stage of the disease. And then the last sentence is, in patients with well-differentiated papillary carcinoma, simple operation is usually adequate. So it's interesting that is in this era of less is more in terms of thyroid surgery. So there's nothing new under the sun, as per Ecclesiastes. So this idea was, even in 1956, was that generally a simple operation is usually adequate to treat thyroid cancer. So with that, that's a brief update on some issues with thyroid nodules and differentiated thyroid cancer in 2020. I'm happy to answer any questions from the group.
Thank you very much. Really interesting. I've learned a lot. You mentioned that Chilean company. Do they just license their intellectual property, or what kind of relationships that they have with the labs? I mean, if I want to get the lab at the hospital to talk to them. Yeah,
that's a great question. I say I'm fairly distant from the company. I don't have any involvement. I did put Hernan's email up there, Dr. Hernan Gonzalez. He is the principal investigator on that study, and he's also I guess the CEO of that company. And so I know that they're partnering with some labs in Europe and in South America. I haven't heard about the Middle East yet, but certainly reaching out to him, contacting him would be something that you would be welcome to do. I don't know exactly how those arrangements work. I do know that the test is typically much cheaper because it can be run out of a local lab, and it doesn't have to be sent in for centralized processing. So, that's the whole reason that I wanted to sort of introduce the idea of this type of genetic molecular testing, because traditionally these tests like Afirma and ThyroSeq, they've been used some in the United States, but it's been sort of cost prohibitive to use these tests in pretty much most other environments, because not only the cost of it, but the technical aspect of having to send in the specimen, across the ocean. So I don't know much at all about the arrangements in terms of that company with local labs, but certainly I can provide the contact information for Hernan, and he would be happy to, I'm sure, share that with you, or he could probably give you guys a presentation on that technology sometime if you were interested in that.
All right. And I'm thinking, with this level of high negative predictive value, this is a big deal. I I would say this could cancel like 50% of thyroid.
Right. Yeah. So I agree with you. I think it's got the newer test, the thyroid print test that I was speaking about, it's got a negative predictive value of around 95%. So if you get a negative result, you're typically not going to need to do surgery, and it's got a positive predictive value of around 75%. So 75% of the time, if you got a positive result, you're going to have a malignancy. So the more that you increase the negative predictive values and the positive predictive values of the test, the more valuable that test becomes, because then you can just do the test and make the decision for surgery based on that test.
Do you ever see it being a first-line intervention or a first-line diagnostic?
I think, yeah, I think probably, I think it will. I think we are heading that way in terms of technology. I think there's the cost factor in terms of exporting that technology to the entire world, and so there has to be a way to do this testing locally, and that's what I think. That's why I wanted to mention this sort of as an emerging technology in terms of something that can be put into a diagnostic kit and be done in a local setting. Right now, it's being done in local labs, but in the future, the next study that Dr. Gonzalez, I think, is planning is he's going to validate it in a diagnostic kit that could be potentially, like, you could put it in any ultrasound lab and then just have it right there to use the kit to get the results. So I think it's exciting about where we could be in a couple of years with this technology.
All right, Dr. Sama, can you hear me?
Okay. Yes, I can hear you.
Osama is a sort of our local expert on thyroid disease. Osama has a question for you.
I'm honored that you listened to the presentation.
Hi, thank you very much for this excellent presentation. Actually, I have a couple of questions. First, do you do sometimes core biopsy for thyroid tumor? Especially for Bethesda 3 and 4. Because sometimes regarding the Afirma test, which we offer at the American Hospital for the patients, but I have some cases where it suggests there is a cancer and we did total thyroidectomy and we ended up by having no cancer.
Right.
So we were a little bit disappointed.
Yeah.
So do you do core biopsy in Bethesda 3, 4 can help you or no?
No, I don't think, no. You should be able to get it from an FNA. The thing about the Afirma test is traditionally it's been 50-50. If you get a positive result, it's 50-50 whether it's going to be cancer or not. So you have to keep that in mind, that I think even with the newest version of Afirma, I think it's maybe 55% or so. It's not much higher than 50% in terms of the positive predictive value. So if you get a positive result, you're going to be in that 50-50 category. The real value of the Afirma is in the negative result. So if you get a negative result, then you're 95% sure that that's not a cancer. A positive result is less valuable. So I think, yeah, we experience that too. We see patients who have positive Afirmas, and half of them are going to have cancer and half of them are not. So it's that's why it's a good rule out test, but it's not a good rule in test. I think this thyroid print study, based on the data that we just published last month in thyroid, it's 75% positive predictive value. So that's 3 out of 4, positive test are going to have a cancer. So that's getting a little bit better, but it's still not perfect. I mean, you're still not 95%. So we've got a little bit of ways to go with the technology before it's higher.
Okay. Thank you. I have other question, which is a case I'm doing next week. Interesting to speak to expert. I have a patient. She's young, fit, 35-year-old. She had thyroid cancer treated by total thyroidectomy. Then she had, it's about 10 years ago. Then 5 years ago, she had a neck dissection on one side. And now she has what I think is a residual disease because her thyroglobulin never came back to very low value. So she has a residual disease on the right side of the neck, which it looked like on the scan, like it is very close to the recurrent laryngeal nerve. So my question, if we find it stuck to the recurrent laryngeal nerve and we can't free it, what's your thought? Should we leave a little bit of tumor or sacrifice the nerve in this situation?
Yeah, can I ask you how old the patient is? Just
she's 36, fit, healthy.
Oh, so she's
lady.
young. She's very young.
Yeah,
Okay.
yes, yeah, very young.
So, yeah, no, I think that's a good point. I mean, I think you're right. I think that's just residual disease that was sort of likely, the most common place, to see this sort of, in the most challenging place to see this sort of residual disease in the central compartment is right at the cricothyroid.
So all seems to happen. Can you hear us, the mic? Everything got frozen. So Sam, maybe you have to speak there. So
Okay, thank you. That's fine.
It's a place where maybe some leave a little bit of residual. I'm sorry, the computer froze for a second. Did you get that? That?
Yeah. No, we did not get anything actually. The answer, we did not get any of the answer. Everything got
okay.
frozen.
I can start over with that. Can you hear me now?
Yes, absolutely.
Okay, sorry about that. So I would say, so as you mentioned very astutely, this is a very challenging problem, and it's a common problem, and it's very challenging, especially in a young patient. So the most common location that's challenging that you see this, residual disease in the central compartment is right at the cricothyroid joint, where the nerve goes into the joint. And that's because a lot of surgeons, particularly those maybe who are a little bit less experienced with thyroid surgery, they get nervous right at the joint and they leave a little cuff of thyroid tissue there. So they leave a little thyroid remnant there. And if there's extrathyroidal extension in that area, there's going to be disease there. And so there's a little bit of disease that's left there. And that disease tends to be very scarred and very stuck to the nerve. So if it's disease that's right there at the cricothyroid joint, then that's a particular challenge. Oftentimes, if you have a CT scan, I'll look at the CT scan. If the disease is not right at the joint, and especially if there's a lot of fat around the disease, like a lot of black on the CT scan, that often means that area has not been previously dissected. If it's lower down in the central compartment, away from the cricothyroid joint, those patients are probably going to be fine with the revision surgery. Their nerve is probably going to be okay. But the disease that is stuck right at the joint, high up in the central compartment, right where the nerve goes in, that is a very high risk to those nerves. And so, oftentimes in those cases, I think watchful waiting for a while is not a bad strategy. It's hard to take a 36-year-old lady if she has disease right at the cricothyroid joint and sacrifice her nerve when she's perfectly normal and not having any issues and completely asymptomatic. So I typically would let them live with that disease for several years and say, hey, this is something that's going to be a very challenging surgery. I think there's a high risk of sacrifice of the nerve when we do this surgery, but I think, we should put it off for a while because you've got good quality of life. And so oftentimes for indolent tumors where there's residual disease right at the cricothyroid joint, I will put those surgeries off for a while, in order not to sacrifice the nerve. And when you do the surgery, I agree with you. I mean, I think it's, in an asymptomatic patient with slow growing indolent disease, I certainly will try not to sacrifice that nerve. I would even leave a little bit of microscopic disease on the nerve rather than sacrifice it in many cases.
Mike,
Okay, very much.
thank you, Sam. Can I ask you to take a look at the chat line? Can we keep for another 5 or 10 minutes? Is that okay?
Yeah, so there's Kenneth. I see Kenneth Baidu from Accra, Ghana. So welcome. I know Kenneth. I've actually spent some time in Accra with Kenneth, so it's great to see him on the call. So let me just look. If we have FNA proved well-differentiated thyroid cancer and unilateral lymph node, FNA of the lymph node cannot confirm, rule out METs, how would you approach the scenario and consent the patient for neck dissection? So I would not operate on the lateral neck lymph node unless I had confirmed disease. So, I mean, I don't do an elective dissection. If there's a lymph node that's suspicious and you do an FNA and it's you can't get a positive result, I would just watch it, because you can still do the thyroid and the central neck surgery, and you can always come back and do that lateral neck surgery later. Lateral neck disease, you know, especially if it's sort of small and indeterminate, it's not threatening. It's not threatening to the patient. You could do that surgery 5 years later, and you know that's going to be a slow growing tumor. So I wouldn't do an elective dissection in that case. So let me just go to another question. What is your opinion about surveillance in small papillary thyroid cancer? I think that's a very good option for micropapillary cancers. My general rule of thumb is that if it's an older patient, it's typically a good option. You know, if you have a 70-year-old with a micropapillary cancer, that patient's probably going to outlive their disease. And so patient's probably never going to need surgery. If you've got a 30-year-old with a, 9mm papillary thyroid cancer, you know, I mean, certainly if they've got something important going on in their life right now, you know, you can delay the surgery. It's not, you know, high risk to the patient, but that patient's probably going to ultimately need surgery. So I think for the younger patients, a long-term strategy makes a little bit less sense. But and then what is your opinion in managing patients in resourced challenging settings? So that's a great question. I have done quite a bit of surgery in resource challenging settings, although not as much as many of you on the call. And it is, you know, it is a challenge. You have to use the available resources. So we did publish some guidelines on thyroid surgery in resource limited settings. That's from the African Head and Neck Society group. You can look that up. It's published open access online. So I think that has some general principles for thyroid surgery in a low resource setting. So without getting too much into it, I would refer to those guidelines for that. And does extranodal extension impact on overall survival or disease-free survival? Any evidence about that? I think if it's microscopic, this is just a brief answer, but if it's microscopic, the answer is no. If it's macroscopic, then I think that it is going to increase your risk for recurrence. So it would affect the disease-free survival. I think it would be hard to probably show an overall survival difference, but that's, and then the next question, in managing thyroid carcinoma, do we have to determine the stadium from the AJCC and directly follow the NCC guideline to establish the proper treatment, or can we only use the risk criteria from the ATA alone? Should we combine both? I think in terms of treatment recommendations, the best result, the best sort of general guidelines would be the NCCN guidelines and the ATA guidelines. The AJCC is typically just for staging, so that's not really guiding treatment. But I think you could go with either the NCCN or the ATA guidelines and be well in line with general thought of high volume thyroid surgeons. And I do think for low risk settings, though, we did publish some guidelines on that. I think you have to modify those guidelines, and we specifically did modify the NCCN guidelines for low resource settings in that publication, because there are specific factors that you have to consider which change your management based on the availability of certain technologies like FNA, like ultrasound, you know, like the availability of thyroid labs. So that's important. I think that's all the questions that I can see. I know that I just ran through those questions very quickly, but I wanted to be sure that I answered all of them, at least in a cursory fashion. Any other questions, I'm happy to answer.
Thank you, Mike. This is really a great talk. Thank you very, very much. And we really appreciate you taking the time with us this morning. Thank you, Will.
Okay, well, very good. I hope to come back someday and give another talk about a different topic or more in depth about the same topic. I have a lot of talks about advanced thyroid cancer too. We didn't get to get into that very much, but that's a sort of a topic.
We would love to have you back. Thank you again. So just please go back to the issue. Please try to download the app. It gives us a way of giving you notifications, changes in the schedule, communicating back and forth, and we could really carry on a much more tailored educational program for you. So thank you guys, and this is now coming up the weekend for us. I know you guys have to work for another 2 days before you get to the weekend. But thank you very much, and have a nice day. Take care.
Bye.
Bye, Mike.